Today's webinar is presented by the South Central Telehealth Resource Center. My name is Wendy Ross. I'm the Assistant Director for the SCTRC. And today, I'm very excited and pleased to introduce to you Ms. Dee Pratt, who is a registered and licensed dietitian and really a pace setter in the world of telenutrition. Dee is the president and co-owner of Dietitian Associates. It's in Memphis. And it is a nutrition consulting and private practice firm in the area. She's been featured on CNN for her innovation for her innovation in hospital food service. She's a recognized leader in telenutrition and reimbursement issues. Her credentials are impressive. She served on many nutrition and dietetics councils, as well as serving for 7 years as the chair for the Tennessee Licensure Board for Dietitian Nutritionists. She's received multiple awards for her efforts, and she is a nationally recognized speaker in the area of nutrition care process. She's presently a member of the NCP advisory panel. She's also been very instrumental in advocacy efforts and bringing reimbursement to Tennessee for dietitians. Really very important. So with that, I want to say welcome, Dee. We appreciate you coming to speak with us in the National Telehealth Resource Center webinar series. And take it away.
All right. Thank you, Wendy. I appreciate it. I was looking forward to today's topic. Let's start with disclosures. I don't know that this is directly affecting anyone, but just to make sure that, in all honesty, for transparency's sake, our company, Dietitian Associates, located in Memphis, has a contract with the Tennessee Primary Care Association to provide medical nutrition therapy for the rural health clinics in Tennessee, and I tell that only because they are a member of the South Central Group for Learn Telehealth, and I think some members even sit on the advisory board. So just for transparency's sake, we will mention that, and I've got to be too careful with this button. So today's objectives are to discuss how telenutrition fits into telehealth. It's to provide information regarding reimbursement for medical nutrition therapy services. It's to address the effectiveness of nutrition services on patient outcomes, and it's to identify ways telenutrition can help reduce cost in healthcare clinics. So what is telenutrition? Well, first, in order to understand telenutrition, we have to understand a little bit about telehealth. And it's interesting because I still have dietitians, when I tell them I'm doing telehealth or telenutrition, they always say, well, what is that? So I think there's still a lot of misinformation about what telehealth is, or sometimes people will say, oh, you're Skyping, and so you have to take a minute to explain. So for telehealth, according to the American Telemedicine Association, telemedicine has been formally designed as the use of medical information exchanged from one site to another via electronic communications to improve a patient's clinical health status. So telehealth is that over-encompassing category that this all fits into. And then we have the term that you'll see sometimes called telemedicine. And telemedicine is more used for groups of people, more like physicians. We usually identify telemedicine. It includes a growing variety of applications, but it's often identified with physicians, where that telehealth is the broader definition for the category itself. And then we come to telenutrition. Some forms of telehealth, by the way, have been going on for more than 40 years, so this is not a new thing. It's just that it's been with radiology, it's been with other disciplines, and not so much with dietitians and some of the practices. But telenutrition, this is a term that was assigned from the Academy of Nutrition and Dietetics. And if some of you on here are members of the Academy, then you can see this on the website. It involves the interactive use by an RD or an RDN, and that's RD used to be our title as registered dietitians, but now it's registered dietitian nutritionists, for most of us use that term, of electronic information, telecommunications technologies to implement the nutrition care process, and that includes the nutrition assessment, the nutrition diagnosis, the nutrition interventions and the plan of care and nutrition monitoring and evaluation with patients or clients at a remote location within the provisions of their state licensure as applicable. And you will note it does say state licensure in this heading or in this definition. You may also see terms such as virtual visits or e-visits, and those can be for nutrition or they can be for other things, but quite often you'll see the term virtual visits quite frequently in some of the literature now. It's starting to become more common. So that too is a term. And without too much attention to it, but for anybody that's on the call that's not a dietitian, and I'm sure there's some, that I just wanted to explain, because a lot of times people don't understand exactly what a registered licensed dietitian is. So I thought I might just throw this in for general purposes, is that what is a registered licensed dietitian or what registered dietitian nutritionist is our RDN. A dietitian nutritionist is the nutrition expert for disease management and prevention and cost-effective care. RDNs are trained in sciences such as chemistry, food sciences, nutrition, human physiology, anatomy, microbiology, and undergraduate studies. And the internship is also a requirement, and recently we've moved up to making sure that people get a master's as well, or above, or before sitting for the national boards. We do have completion of 75 hours of continuing education every 5 years. We're licensed in most states. Most of the states across the country are licensed, and certainly Tennessee is one of those, and we have been since the early 90s. Approximately 1,600 RDNs and student interns are in Tennessee, but we have approximately 75,000 RDNs in our national association, which is headquartered in Chicago. And we also have a large delegation of international members. We recently were at the conference for dietitians in Boston, and I think there were 20-something countries that were there represented. So we do have quite a large international group. Our RDNs practice evidence-based information. We don't just take information for granted, such as sometimes things like can't eat any white food or that kind of stuff. We do use evidence-based practice. So in 2013, when we first started to investigate telenutrition as a possibility, there was hardly any information out there to find. It was only like a one line hidden behind in a document that said something to the effect that dietitians could be reimbursed for MNT. And that was about all that was out there. There was hardly anything we could locate to give us the real information. I made a call to the head of reimbursement at our National Academy, Marcia Schofield, and I told her that I knew, asked her if she knew of anyone that was doing telehealth. She told me she didn't know of anyone other than somebody that was in a university. I did make some calls. I know that the VA hospital has been doing telenutrition for a while, and some universities and hospitals have been doing some, but unfortunately they had not been reimbursing for their services, so I didn't get much information that way. I contacted, probably within the next 5 months of research, I probably contacted at least 50 people that were up and down the ladders of CMS to try to get some information as to whether dietitians could reimburse or how they would reimburse or what the rules were. And I found that no one could tell me anything. And that was in 2013. And now in 2016, it's just amazing how much that every time you do anything or search anything on telehealth, you get tons and tons of information. So those of you that are just starting, you're very lucky that you're coming on board when you are, because there was nothing for me, but there is lots of information now. And I do think it's going to be around for a long time to come, and it's going to be where our profession is going to be going. Our first site was actually in Arkansas, where Miss Wendy is, And I kind of figured that if we made it across state lines, that it might work anywhere if I could get it to figure out all the systems. So we took our first client actually in Arkansas in 2013 across the state lines. And I didn't take but one patient because I wanted to make sure that I was going to get reimbursed for it. So I waited 2 or 3 weeks before we received payment. And then I wanted to make sure that, you know, everybody got paid for that service. So that's kind of where we started. But what are the benefits of telenutrition? Well, first of all, is that there's the improved access. If you look at what's been going on, there's, I'm not sure if I missed a slide or not on this, but maybe I didn't. But there have been really high insurance rates. You know, that there's hundreds of thousands of folks that have no insurance. Unsustainable spending. If you go to a hospital and you spend $10 for an aspirin, you know that that's really excessive, just when you can buy a whole bottle for that. You know, I had a partial knee replacement a few years ago, and it was like $88,000 for a partial knee replacement. So I always remind myself that I'm lucky that I didn't have to have the whole knee replaced, because I probably couldn't have afforded it. There's a lack of emphasis has been on prevention for all these years, that only about 3% of the spending for healthcare has been used for preventive. And so whether you like the Affordable Care Act or not, it's done the one thing for dietitian, and that's opened up the door for preventive services. And now patients are able to see the dietitian, and most of their visits are covered at 100%. So telehealth, we found, works really well with preventive patients as well. It's something that goes hand in hand with it. The other thing is poor health outcomes. You know, in the past, we haven't worried so much about health outcomes. We've kind of gotten paid fee for service, and that's all changing with the bundling of payments and patient-centered medical homes and other things. And so now we're having to look at better outcomes, because that's how we're going to be paid. And although dietitians are still paid fee for service, that probably won't last that long as well. It'll probably be changing in somewhere down the road, and who knows what will happen with you know, the changes that are being talked about these days on the television. Also, there's been a lot of health disparities. This is where telehealth and telenutrition are really, really popular, because according to the Affordable Care Act, says that people that live in rural areas should have the same care that the rest of us that live in the larger cities. And that's not been the case. Most of these people, or a lot of these people, could not get to their doctors, get to the same care as we are able to get in a larger city. So for them, the telenutrition is an opportunity that they haven't had. Sometimes there's not even dietitians in some of the rural areas. And if there are, sometimes they've not been able to keep up with a lot of the educational opportunities, or there's not networking for them. And sometimes the information they have hasn't been quite as up to date, not through fault of their own necessarily, but just the way life is in a rural area. So the benefits for telenutrition, first of all, is the improved access. It can bring healthcare services to millions of new patients in a distant location that might never have care, because there's not dietitians in most of these areas where we see patients. And I think as an example of it is that I had a patient who was a brittle diabetic, and she's 32 years old. She'd had diabetes since 14 years old. She did not have transportation to leave her town. She only depended on people to get her to another location by paying them to drive her someplace. But she's never seen a dietitian in her 32 years since age 14 of having diabetes. She's never been able to see a dietitian. And when we met by telenutrition, she was so excited. She came back the next visit. She was feeling so much better. She had lost some weight. She said she, was on track with her diet, but she never had even left her town. It was a small community, and she had never even gone outside of her town, even though we're only about 40 minutes from Memphis to where she was. She'd never been to Memphis. So because it was for some people, it's kind of scary to drive into other areas or to get somebody to take you. The patients that we see seem to be really, really grateful for the service. Cost effectiveness. It helps to reduce or contain the healthcare costs, especially with patients that can be treated where they live and not have to drive long distances. We have patients that will sometimes drive 3 hours to get to our offices, and we try to tell them, hey, is there not somebody you can see? And we find out that there's not anyone in their location. And I'm going to show you a slide in a few minutes from the University of Arkansas that I think kind of brings it all kind of home. That's an excellent slide. But improved quality is the next thing. Studies have consistently shown that the quality of healthcare services delivered via telemedicine or telenutrition are as good as those given in traditional in-person consultations and prevent fragmentation. Treatments now focusing more on self-management than it used to and on preventive rather than the fee-for-service. So I think we can definitely show how we can improve the quality. And I'll share a slide with you, a couple of slides in a few minutes, also on how we've improved the quality in some people's lives. And then under patient demand, patients like the telemedicine because it reduces their travel time and other stresses that and the inconvenience of having to go somewhere to see someone. Next slide, please. So how does telenutrition fit with the triple aim? I think probably a lot of you are familiar with the triple aim in healthcare. And so the telehealth actually fits quite well. The Institute of Healthcare Improvements, triple aim for healthcare requirements are that it should improve the health of the population served. And not everyone has been able to get the healthcare that they need in some of the smaller rural areas. The experience is better for people to improve the experience for the individual. It's usually better for the patient. They have no longer to have to spend a day driving. Most of them like to stay in their own community. They're familiar with their doctor and the nurses that take care of them on a regular basis. So that's a little more comfortable. Sometimes when they have to drive a long ways, they're uncomfortable driving in the city, and then it's hard to concentrate because they know they have the long drive home. Lower cost through improvement by promoting preventive medicine. And certainly you're going to see that in just a few minutes on this next slide. If you watch for the telehealth websites, you see that there's lots of money, millions and millions of dollars are being put into telehealth. And it's, some are going to many states, some are going to isolated areas. As I think I've mentioned that maybe only 3 cents out of every dollar is spent on preventive. And so we're looking at other better services and ways to lower those costs. Next slide, please. So this is a study, and this is from the University of Arkansas for Medical Sciences, where Wendy happens to be from. So I threw this in for Wendy's benefit, but I think it's a great, great slide. This was a study that was done from 98 to 2002 out of 410 consults. This, without telemedicine, 94% of patients will travel greater than 70 miles for medical care. And as I said, we have many that will travel 3 hours to get to us. We had someone the other day, it was almost 4 hours, and I'm just amazed that people are willing to do that, but I know that, they're more concerned about their health care. The other thing is that they're 84% would have had to miss a day of work. 74% would spend $75 to $150 for additional expenses. Now, this sometimes could be daycare, it could be meals to have to travel, it could be any number of things that would fit into this category. And then with the telemedicine, 92% saved $32 in fuel cost, 84% saved $100 in wages from having to take a day off of work. and 74% saved $75 to $150 in added expenses. And that may not seem much to some of us. I mean, if you go to a restaurant and you spend $32, that may not seem like a whole lot, but for a lot of these folks that don't have the better paying jobs and so forth, you take off a day of work, $100 is expensive, and $32 even in fuel cost or having to pay someone for that ride. So I think this is just a great slide that brings it kind of home. Next slide, please. So some basic requirements for telenutrition is the real-time, face-to-face versus store and forward. Real-time, face-to-face is meaning that we're actually talking back and forth on a camera. I'm showing you education materials and so forth, versus store and forward. And for nutrition, you will see that sometimes that you have to keep in mind that some of the information that you read on the site may be that it's okay to store and forward. That's not for dietitians necessarily in all cases. Sometimes it's for other disciplines. So you have to really check out what's nutrition related and what might be for other disciplines. Store and forward would be like if I recorded this session and you looked at it later, you would not be able to answer my questions face-to-face, but you could look at my information later on today. As far as I'm aware at this point in time for dietitians, the only two states that I'm aware that it's legal to do store and forward, one is Alaska and the other is Hawaii. And there may be some changes in that, but I have not heard of it. So just be sure that, when you store and forward, sometimes it may be for a dermatologist or neurologist or something else, and it may not be for you. So check out the information that you're getting. The information changes very rapidly for dietitians and for everybody else. So you really have to keep on top of every day of kind of, has anything changed kind of thing, because it has changed so quickly in the last 3 years for us. It's just unbelievable. The second thing is that some of the requirements is originating site versus distant site. And I think this is confusing to a lot of people, and quite frankly, it was to me. I thought I was the originating site till I thought that through. But the originating site is where's the patient located. That's the originating site because that's the person that did the referral in the first place. And if you can think in terms of where was it referred from, that's the originating site. The distant site is where is the dietitian located. So you are the distant site wherever you happen to be sitting. If you're in your home office, you're in your office building, or wherever you might be, you're the distant site. So does the location qualify for reimbursement? That's really important for you to know. Somebody asked me recently if this covered you in town seeing patients. Well, this is about rural health. It's about telehealth. And at this point in time, it's in rural areas. It's not gotten too much into in the same city, because the whole point of telehealth and rural health is giving people in rural areas an opportunity like they would have in town. The ones in town already have that opportunity usually. So you've got to check out the location, and I'll show you that in just a minute. How do you determine that? Because I think that's very confusing to a lot of people. You also need to look at your internet to make sure that it's strong, because particularly in rural areas, a lot of their internet systems are not that great. So you got to make sure that not only yours is strong, but that you're telling them what they're going to need to make sure that theirs is strong enough for you to provide the service. Next slide, please. So what location? So this is the information that you're going to need for your locations to determine whether or not they qualify. The first thing is that the originating site has to be in a rural health professional shortage area, or an HPSA. And this is a professional is in order that how many doctors do you have to the number of patients in that area? So that's the first thing. And the second one is in a county that is outside of the metropolitan statistical area as defined by HRSA and the Census Bureau. So how many people are in that particular area? It could be in a federally qualified health clinic if they're doing a demonstration project. And I know they're doing some of those around the country, Alaska for one, and some other states as well, where they're trying out telemedicine. It's not supposed to be in a patient's home, but there are some exceptions. And one is that I know in the state of Mississippi, they've received a grant for diabetes to be in the home. And so everybody in the home that's in this program for telehealth has a iPad, and they have testing devices for diabetes and other things. And so the clinics check in with the patients, and they do telehealth that way. So there are some dietitians involved, I think, or some CDEs involved. So there's some exceptions, but it's not typically that it would be in a patient's home. To bill Medicare, the originating site should be located in a medical facility, such as a practitioner's office, a critical access hospital, skilled nursing facility, a federally qualified health center, a mental health clinic, or a rural health clinic. So those are some of the places that they would have to go to be approved. The other thing is that the site where a physician must be for Medicare has to be, he has to be a Medicare provider in order for you to get paid as a dietitian. So you need to check that out and make sure that he is a Medicare provider. Most often you will find that in the smaller areas because they depend a lot on Medicare for their payments, where that in town we don't always see doctors accepting Medicare, but just double check that. Next slide, and if that's not confused you enough, then let me just show you how to know what's approved and what's not approved, because when we first started, I lived on this slide that's in front of you for eligibility analyzer, and this is with HRSA, which is the Health Resources and Service Administration. If you're not familiar with them, you should get familiar with them, but this is on their website. So if you're not sure whether or not your clinic fits into the category to be paid for, then go to this site, put in your street address of the clinic, and sometimes it will pop out and you'll have to put it back in, or maybe you didn't say south, or it'll ask you, did you mean south or north? So make sure that you put in the exact address, because it will not always share with you. The other thing is that just because that it might show you, if you do the search and it shows that it's an approved site for you to do telehealth, make sure that you double check it maybe next year, because in January of each year they change sometimes, and that sometimes people will drop their status, maybe that there's something changed in the area that is no longer considered a professional shortage area, an HPSA. So you need to research that if you're doing clinics around, because they can change from time to time, and you might not be aware of it, and then you'd wonder why you didn't get your payment. But this is probably the easiest way to go to this site. I looked up hundreds and hundreds of addresses before we started doing anything. So it will be a really helpful site for you. Next slide, please. So who pays for RDN services? Well, it started out with us. It was Medicare only because that was all that was available to us, and I'll explain in just a minute. But Medicare pays for diabetes, and it pays for chronic kidney disease for stage 2, 3, or 4, or 5 if they're not on dialysis. Same as they pay for it if you're in an office somewhere. So that's the only thing that Medicare is really paying you as a dietitian in your own office, but it's the same as it would for anything else. It also pays for the DSMT services. That's the diabetes self-management training programs that some of the hospitals or some of the clinics have that program, and it will cover that. If you have that program, it will also cover that. They're saying they cover some behavioral health, but again, that has to be filed services through the physician's office, not through the dietitian. Private insurance carriers, when we first started, we were only being reimbursed by Medicare. because that was all that was available to us, and it still is in some places such as Arkansas. I'm hoping they will change some of that, but right now in our clinics in Arkansas, we can be reimbursed for Medicare, but not for anything else. But in Tennessee, in 2015, they passed a parity law, and a parity law said that if we could get payment from Blue Cross or Aetna, some of the other insurance companies, then they also have to reimburse through telehealth for those same services. So we were fortunate enough that we were already accepting several of the insurance companies and had been for a number of years. And so because of that, the parity law covers us to be able to bill for those services in Tennessee. Now there's about 30-something states that already have parity laws, and you just need to check out yours in your state and see what yours provides for your services. So if you have a parity law, you know, I think there's probably at least a dozen more that are working on parity laws for telehealth, but that gives you the right to be able to charge insurance companies. So what codes do we use? Well, we use the same codes that we use for anything else. We use the 97802 if it's initial. We use the 97803 for CPT codes if it's a follow-up. We usually do not do group classes. It would be very difficult to do group classes on telehealth, and we've also found them not to be as effective for us as individual counseling. So basically, we use the same CPT codes that we typically would use. Those are dietitian codes. If there's others on the call that are not dietitians, the 97802 and 803 are dietitian codes and are to used by a dietitian. So how much do we get paid? We get paid the same thing that we get paid in our office. I mean, for example, if it's Medicare reimbursing, they reimburse the same thing via telehealth as they do for what an in-office patient would pay for. When same thing with Blue Cross, they pay us exactly as the same as they would pay us if we were seeing patients in our office. And although we can't discuss those numbers, in Tennessee, we are required to have a consent to treat. That's not the case in all states, but you need to check that because that is the law in Tennessee that we must have a consent to treat before we can see patients, and that's in person or on telehealth. How do we bill it? Let me go to the next slide and we'll show you how to bill it. This is just to kind of explain for those of you that fill out the 1500 forms. The billing is exactly the same, except that if you look where the yellow is on this slide on the 1500 form, there's a GT modifier that must be put on that code. GT is for the telehealth. It has to go on all telehealth patients. So it is a modifier that goes on every one of the forms that you fill out. If you had a patient that you knew was not going to pay for Medicare, was not going to pay for, and you had to use the GA code, you would use the GT, and then you could use the GA modifier in the next block, so that would be covering that you knew that Medicare wasn't going to pay for it. Okay, and next slide. All right, this just shows the effectiveness of how telehealth can be effective for us. This was, one of the questions that people always ask me is, well, do you think patients get as much out of it as they do in person? I really do believe they get as much in, this was a patient that came to us for 4 months straight, and this was their results. This was a guy, he started at 203 pounds, and over the period of 4 months, he dropped to 186 pounds. He lost 17 pounds or an 8.4% drop. So I think if you look at that, you can easily tell. We're in the process of doing a study for the last 6 months, and hopefully that will be out in the next month or two with a kind of a recap, and might be able to share some of that with you. But it's really significant changes in patients using the telehealth. They're comfortable in that environment. They're comfortable where they are with the people surrounding them that they know, and they've been usually quite successful. They're appreciative of the opportunity to learn. for the most part. And, once you get them in, you usually will get them back for second, third visits. Some of them want to keep coming. You have to sooner or later probably cut them off because they may not have that many visits, but usually there's 3 to 6 visits with Blue Cross, and some of the insurance companies are at that, and it's 10 visits a year. So that gives you an opportunity to see them where there's 3 hours with Medicare. Medicaid does not cover in most states, although that Medicaid is now starting to cover. Our visits for patients are usually 1 hour for telehealth for the initial assessment, and then they're usually about 30 to 45 minutes for a follow-up visit. So next slide, please. All right, this was the second one. This was a 42-year-old female. She had diabetes, hypothyroidism, and she was hypertension, glucose. So if you look at this particular one, this lady started out around 306 pounds. She dropped to 30 pounds to 276. Her BMI went from 50.6 to 46.2. Her A1C is now at 6.4. Her blood glucose has dropped from around 200 down to about 100 to 110 in the morning, which is really, really doing well. You can see from the third slide down there the changes that have occurred over the past 4 months for the blood glucose. And if you take that into consideration, the fact that she has dropped her weight, she's dropped her blood glucose, she also dropped her insulin. And when you think about that, I mean, with 10 units of insulin, I think it was like almost $1,000 a year difference. So you can see how it's we can sell ourselves in patient-centered medical homes and other types of facilities because, or types of models of affordable care, because we can make a big difference. We've seen people get off of Linzess, if you're familiar with that drug, and that was like a $4,000 or $5,000 a year savings because they were able to change their eating habits and to get off that. So next slide, please. So the pros and cons of telenutrition. It's not for everybody. I'm not going to say every dietitian that might be listening today or anybody else that should go out and start telehealth, because I don't think it's for everybody, and there's a few reasons why. The pros for me is that it's the satisfaction of helping patients, which comes the same as it would for most anyone. I find it very satisfying that patients seem so excited that they're getting something they wouldn't be able to normally get in their own community. It's a new revenue for your business. If you want to bring in more money, it's a way of doing that. Generally, it's less time allowing more time for the patient. And I say that because sometimes when you have them in person in your office, they want to visit or they want to talk about other things, and they want to look at your sample rack, or they have lots of things they want to chat and get to know you before they start. With telehealth, you kind of just go straight into the visit, and you don't necessarily spend all that extra time with a patient. And that can be good and it can be bad, but it is generally saves some time. You can work from home, or you can work wherever you want to, so you don't have overhead from having an office. RDNs can work, anywhere as long as they're licensed. You do have to be licensed in the state you're practicing in, as well as the state in which you are providing the service. So, for instance, I'm licensed in Mississippi, I'm licensed in Arkansas, and I'm licensed in Tennessee, because those are my areas of providing service, where that some of the other staff members are licensed in additional states, and maybe not all the same ones. So we have 5 dietitians on staff, and so our dietitians are licensed in multiple states. So, but the good part is you can get that license relatively easily, I've found, in most states. So Tennessee actually has one of the hardest to get. So what are the cons then? The no-show rate has been a little bit higher with telehealth than it is with, we find, with our outpatients. I don't know exactly what it is. I think sometimes it has to do with the facilities don't call, remind their patients, maybe where we do in our offices. Staff members are not always supportive, and we've found this to happen a few times, is that maybe the staffs feel like that they've got to spend time getting the patient the information, and they think that they don't think about the fact it's helping the patient. They think more about the fact that they're having to do a little bit of extra work. That doesn't always happen. It does happen from time to time, and it has been a factor in some cases. For some, it's less personal contact with the patient. Out of my 5 dietitians, one of them feels that she doesn't have that personal contact, and she misses that a little bit. For the rest of us, we all feel like we're getting as much personal contact as we need with the patient, that they kind of build a bond. And it was kind of comical because she had made the comment that you don't get that. And then that year that she made that comment, when Christmas time came around, I got Christmas cards from my telehealth patients, and I asked her how many had she received. Well, her in-house patients had not brought her any Christmas cards or sent her any, but yet my telehealth ones felt like they knew me well enough, or that they will call me by first name, that they're excited to see me when we're doing a follow-up session or two. More work is in providing written education materials. And what do I mean by that? First of all is that you pop your information, education materials up on your screen while you're working with patients. So you need to make sure that you get all of those prepared and that they're legible and easy to read, so that you can just go straight to them and pop them up. You don't have time to be hunting for education materials in lots of different directions. So you have to get those done in advance. And then if the internet ever goes down, then that's definitely a con that I could mention. But fortunately for us, I think we've only had that to happen once in the last 3 years. So we're pretty fortunate for that. Sometimes there is some difficulty, but most of the time it will work out if the other side has a good computer system as well as ours. So next slide, please. So what do we need to get started? Well, first of all, you need a computer with a camera, because this is face-to-face, and it has to be face-to-face, except in those states I mentioned. If you don't have, all of our computers have cameras hooked to them. If you don't have a camera, then you may want to purchase a little add-on camera. They're anywhere from $50 to $200. We have one in our office we gave $200 for, and it's really great. It automatically moves around and it does all kinds of stuff, so you don't have to go that expensive. High-speed internet, 7.0 or above is usually recommended for the strength. And again, you need to inform the people on the other side of that aisle that they need to make sure that their computer, internet, and the computer system are strong. Telecommunication services, that it's an encrypted. And Skype is not, even though Skype has some encryption, it does not give you a BAA agreement, so it's not an approved method for telehealth. And that being that the BAA agreement is saying that they are going to be there for you, that they're so sure that their system's not going to be hacked or interrupted, that they're there with a agreement saying that they're there to show that they have support for you. And so you need to be sure that you have that BAA agreement before you start seeing patients. And if you're going to do Skype with somebody, then you need to warn them that your system is not totally encrypted, so their information could be hacked. You need to have education materials for all patients at different levels, because there's lots of times when you'll see patients with something you didn't expect. And you just have those on your backboard so that you can pull them up when you need to. And then liability insurance covering telehealth counseling is very important. I know if you're a member of the Dietetic Association in Chicago, that they have that coverage now, that we have it in our office. EHRs for charting is helpful. We do ours by computer. So that we can be doing it while we're talking to the patient sometimes and adding some of that information in. Licenses, as I said, you need one for where you're working and the distant site, and one for the originating site if they have licensure. And then space for counseling. You need to make sure that your space is free from noise and distractions. that's really important because they need to be able to hear what you're saying. You need to be able to hear them. And sometimes it's a little difficult if you're in a noisy location or where there are people coming and going. That's not HIPAA approved either. And then good bookkeeping records. There's lots of record keeping that goes along with telehealth. So just making sure that you have that. Next slide, please. And these are some of my sources. Obviously, Learn Telehealth is sponsoring us today, and I've used that site so many times in the last 3 years that you wouldn't believe. That's how we all kind of connected with this talk. HHS, there's many, many more. There's things, if you're a dietitian, there's many on the eatright.org website now, americantelehealth.org. There are many, many sites that you can pull up the different sites or just Google telehealth or telenutrition, and you'll get tons of stuff. And next slide, please. And this is my information. And I think that the next slide is for questions and answers. So I'm going to stop there to make sure that we get into the questions.
Great. Thank you, Dee. That was so interesting. I'm trying to pulling up the questions now so we can ask. We've got several questions.
Okay.
The first question I'm going to ask you is from Diana. It says, is video a requirement? Can you talk about other forms of virtual nutrition services that seem to be popping up?
It is required for you to be able to get paid for it. If you're asking for reimbursement, the face-to-face, the camera is required to use that if you're doing that. If you're doing virtual as in conversations back and forth with someone, again, is it encrypted? Is it safe? That kind of thing. But for the face-to-face with telenutrition, to be able to get reimbursement, it does have to be with a camera.
Great.
And you need the camera also to show your education materials. I pull up my education materials, I circle things that I want them to look at, maybe on a label or something I'm talking. So they need that to be able to see it anyway.
Okay, thank you.
Mm-hmm.
Another question from Kyle. It says, you reference originating site and state that the patient must be in rural area and at qualifying location. And this is a known Medicare requirement. However, do third-party payers actually enforce these same guidelines? There's a little bit more to the question, so let me pop that out there too. Most third-party payers promote telemedicine platforms, such as like Teladoc or Doctor on Demand, to their patients, and these platforms allow the patient to be at home, and the patient does not have to be in a rural area to receive this care. How would the requirements be any different for telenutrition?
A lot of the requirements, unfortunately, are different for telenutrition than they are for some doctors or for some types of disciplines. And again, you'll need to check. There also are some states that are kind of moving ahead trying to get telenutrition or telehealth in the patient's home. And as I said, in Mississippi, I know that they have a program particularly that's doing that. And there are some other states that are trying to get that passed as well. I'm looking forward to when we can see patients in their homes. But the problem is that, yes, that for us that the third-party payers do require it be in a rural health center in order for us to get paid. But the problem would be if it's all in home, unless the program is going to pay for iPads, we find that most of the people in these rural health areas do not have home computers. I know that sounds strange, but there are lots of people. We try to send them education materials sometimes by email, and it's amazing how few of them have computers to download that to. That many of them may have computers for their children to do something, but they don't understand how to use them themselves. But a lot of them do not even have them in their homes.
Thank you. Okay, I've got a question that's asked from Stacy that's saying, what telecommunications services have you used or others used that you have found to be successful?
our platforms have been, right now we're using Zoom, and that's is really a good platform, I think, for us. Some of them are not cheap, and when I say that all dietitians probably don't need to go into telehealth, they might want to look at it from a different direction, maybe in a center, because some of the telehealth platforms can become very expensive. But we're using Zoom. We have used VC. I love VC as well. VC is very, very user-friendly. Zoom is a little bit more, probably the visuals are a little bit better with Zoom. Sprint has some. Cisco, CISCO, not Cisco is the food company, has platforms. There's many platforms, and there's lots more popping up. I get emails from time to time on listservs that try to sell me new services with other companies. So you need to look at what your needs are, and are you going to be seeing enough patients by telehealth to pay for that technology? And I think that was kind of a drawback, I think, with a lot of dietitians has been that it's too expensive to pay for the platform. So if there's a way to do it through a grant, or maybe through a VA hospital to see if you even like it before you go investing in it, that might be one way to go. But generally you can pay on a monthly basis if that helps your business model, for sure.
Okay, good. We have a few more minutes, so we're going to try to get in as many of these questions as we can. And if we don't get them all, what we'll do is I'll follow up with the questions with Dee, and then we'll put something on the website with the answers, or we'll figure out a way to get you the answers. So just a few more questions then. One question is, how does she handle the appointments? Is it through the appointment software or EMR, or just on your own calendar?
All right. We handle ours. We do have an appointment schedule. We do it through Office Ally. I know a lot of the dietitians use that. And we do our scheduling on Office Ally. And we find it works pretty well to do it that way, because you can set it up with multiple users' appointment logs. So that's usually how we do that. I think there was another part of that question, but I've forgotten what it was.
I actually just took it off my screen. Okay. Sorry. Well, I can't get back to it now. I apologize about that one. I'll go back to the question list. I can't, let me go, oh, I'm sorry, let me go to this screen. Okay, it was, how does she handle appointments? Is it through the appointment software, EMR, or just in your own calendar? So.
Oh, maybe I did answer it then.
You got it.
Yes, it's Office Ally for us. I know there's lots of different schedules out there, but we do use Office Ally.
Okay, one more question for you. Are there only certain disease states, conditions you can provide telenutrition for?
Again, it comes back to the parity law. If you have a parity law that allows you, we see a little bit of everything. We're in the process of doing a grant that covers diabetes and hypertension and obesity, but we also see sometimes maybe an eating disorder, we see a celiac, or we see a cardiovascular type disease. So as long as the insurance is covering it, like with Blue Cross, for instance, they have preventive, and preventive, if you use the Z71.3 for preventive, you can cover a lot of things with that in the insurance. Because of our parity law, it allows us to get reimbursed for most anything, or the same with like Cigna or some other insurance company. As long as we have that parity law, it allows us to bill for lots of different types of diseases, where that Medicare, we only have those two that we can bill for. And for those that have Medicaid that pays for nutrition services, well, then you're fortunate that you can also bill Medicaid. And so we use all codes during our processes because of our parity law.
Great. Okay. Well, I think that's all the time. We've got a ton more questions, but we're running out of time here. So again, I'll follow up with I'll send you this list of questions if you don't mind, Dee. We'll get the answers and we'll post that. We'll post the slides. I know one of the questions was if they could have a copy of the slides, and we're going to post an archive recording for this as well. It's been a wonderful wonderful presentation. It's so interesting. I have a lot of questions to add of my own.
Well, I hope it's been helpful for everyone.
It was great. Really enjoyed it. So just quickly, I want to thank everybody for attending. Of course, I want to thank our wonderful presenter today. And I want to let you know that the next webinar, which is again the third Thursday of every month, the next webinar is what you need to know about telepharmacy, which is another hot topic. And we'll talk about things from regulatory environment and et cetera and so on. And this wonderful presentation will be hosted by the Upper Midwest Telehealth Resource Center on Thursday, December 15th. So we would like everybody help us do a better job or finding the right topics, or let us know if this was a good topic for you. I put the link on the screen. It's www.surveymonkey.com/r/HTT97R9. And we would love to get your feedback. And with that, I wish everybody a happy afternoon.